So the two medications, and we'll use brand names here. I normally don't like to use brand names, but we'll use them when so that they're more clear for patients in the community. So one is called Cabenuva. That's the medication that's used for HIV treatment. And the other is called Apertude. That is the medication that's used for HIV prevention. What they both have in common are that they are both what I describe to patients and my colleagues as deep intramuscular injections. So they're a little different than your regular intramuscular injections. They have to be done by nurses who have been trained just a little bit differently to make sure they do it the right way. So they're both these deep intramuscular injections. They're actually both now available as bi-monthly or every 2-month injections. They actually sort of follow the same schedule where you're given your initial injection, you're given one month later as a loading dose, and then you take an injection every 2 months, every 8 weeks, essentially. The big difference between these medications is, first of all, for HIV treatment, it's a combination of two medications. So it's two separate injections, one in each buttock, one medication in each buttock. For HIV treatment, for Apertude, for prevention, it's just the one injection in one buttock.
Dr. Cantor, you really set us up really well because I think you clearly have a clear sort of centering of your patients and the way that you're sort of talking about things. Because I think one of the first things that I'll say about long-acting injectable is it is exciting. I also, as a community advocate, am very cognizant of the price issue with this. So when you're looking at $22,500 a year for Apertude compared to less than $20 a month for generic TDF-FTC or generic Truvada, this is going to be a complicated intervention to get to people. And I do worry as a community advocate, given that, there's such important adherence requirements if you're going to be on this, that, community health centers are checking with patients and really making sure that they're not going to run into any sort of unexpected coverage issues or anything that's going to interrupt their ability to continue with their treatment in terms of all of this.
In the grand scheme of things, over $22,000 a year for a list price for an ARV is in the upper threshold of ARVs that are available for HIV treatment and prevention. So it's not an insignificant list price. If we talk about community health centers and their status as 340B entities, there's a discount available to purchase that drug for your uninsured population. And yet, even with the discount, the price is still fairly significant. So that's an important factor as community health centers look at budgeting and programmatic decisions on both routes, on both Apertude and Cabenuva.
So one of the things that we're doing, particularly with Apertude, is we're having people, when they refer their patients to us, is to give us an indication as to the reason why we could prioritize them. And we're really trying to make sure that, specifically with a focus on our sex workers, on people that just absolutely positively cannot swallow pills and are, at continued risk, our young people. We have a big adolescent program, people that that really are struggling with very easy to access oral PrEP. Or for whatever reason, there are people who should not do on-demand PrEP, which is a great option for people who maybe don't want to take pills every day, but sort of making sure that those people who this essentially directly observed therapy is really the best option for it. So we're trying to make sure that we have sort of indications for those people to prioritize them.
You could have the best intervention in the entire world, and we do. We have a pill and now an injectable that prevents HIV. We have a medication that prevents HIV, and very few people are taking it. So I think we can all day long talk about these new things coming down the pipeline and be very, very excited about injectables, and I am, but we haven't fixed the fundamental flaws in the financing, delivery, and access systems. And until we do that, I think we are just going to be talking about growing disparities in who's able to really, thread these very complex systems to get them.